Okay, I think we can start now and the rest can join us later on. So good evening, everyone. Welcome to our online talk on hypertension in the COVID-19 era. My name is Anita Otsula and I'm the National Officer of SCOHE in Kenya. Today I'll be moderating the meeting with Abdirahman, who is our representative from SCOHE. So we're excited to have all of you here today, and I'd like to recognize all the officials who are in attendance. From SCOHE, we have our director, Innocent, and we have the director from SCOHE, Chinaza, all the national and local officers, as well as those from finance, monitoring and evaluation, and program and design. Thank you all for making this happen. So first, I'll give you a brief overview of our organization. So FAMSA is the Federation of African Medical Students Association, and it's a body of students, medical students from all over Africa. And there are various committees under FAMSA. The one that I belong to is SCOHE, the Standing Committee on Professional Exchange, and we organize clinical exchange programs for medical students. Unfortunately, now there's COVID-19, but we'll be up and running later on. Then we also have in attendance SCOHE, and I'll invite Abdirahman to tell us a bit about SCOHE and also to introduce himself. So Abdirahman, you can.
Yeah, can you hear me?
Yeah, I hear you.
Hello, everyone. Welcome to today's session entitled Hypertension in the COVID-19 era. I'm Abdirahman Muhammad, and I am a medical student and also a national officer of Standing Committee of Health and Environment in Somalia. And I and Anita, we will be working behind the scene of today's webinar. Before we begin, and I would like to thank our Dr. Namazuka. And lastly, we also welcome questions and comments throughout the session via the question and answer box. But you are also welcome to send any technical issue to us, and thank you.
Thank you, Abdirahman. Without further ado, I'd like to introduce our speaker for the day. Dr. Namasaka is a senior lecturer at JKUAT School of Medicine, a consultant and a cardiologist. So today he'll be discussing hypertension in relation to COVID-19. Karibu sana daktari. We're happy to have you.
Okay, good. So I think I will start. I think the first time I was given this talk to talk this, I was a bit hesitant because the notice was a bit short. And then I finally said, I think I can be able to give something. So I think we'll talk about hypertension. I don't know why this is so. Usually when you start a talk, you try and say the conflicts that you have. So just in case you're a bit biased. So I have received honoraria from the following companies for some talks that I have done previously: Savia International, Novartis, and Merck. These are others. Of course, maybe I've had one or two other interactions with others, but this was the ones I'm remembering. So I don't think that my talk might have any conflict. The other thing is that in preparation for this talk, I assumed that we will have first years listening, and then we will also have 6th-year medical schools medical students listening. So it might not exactly go the way you wanted. However, I've looked at the participants and I'm feeling like there are even less attendance than one of the classes or two classes that I have. So it becomes a bit more difficult, the assumption. And two is that I've borrowed heavily from European Society of Cardiology, sorry, it's supposed to be ESH, and European Society of Hypertension guidelines. I've borrowed heavily from there. And then finally, I hope that you shall have some messages to take home after this talk. So generally, what will we say is a definition of hypertension. Hypertension, therefore, is just generally a blood pressure that is more than 140 over 90. And this is a European classification. I decided to borrow heavily from the European Society of Cardiology and European Society of Hypertension, because if you go to the American guidelines, they're slightly different in form of cutoffs. And therefore, as a basic talk, if you try to combine both, then you'll find that your listeners, if, for example, they are the younger ones, first years and second years, become a bit confused. But having said that, is therefore, you will have optimal hypertension, then you'll have normal hypertension, and then you'll normal pressures, optimal pressures, then you'll have normal pressures, and then you have high normal pressures. And the reason why there's this classification of optimal, normal, and high normal is that if you look at these high normal patients and you follow them up for like 5 years, almost 10 to 15% of them will develop hypertension. And also, having said that, is that generally as you grow older, your pressures tend to gradually increase as you get older. And that will explain why hypertension is more prevalent in the older. But also having said that, is that some people in this group may be put on treatment for hypertension depending on the cardiovascular risk. And then based on that, there is also classification based on grade 1 hypertension, grade 2 hypertension, grade 3 hypertension, and isolated systolic hypertension. The fact is that, for example, if you are in grade 2 hypertension, then if it comes to treatment, don't bother with single therapy. Then you need to combine your therapy in form of 2 drugs. So those are some of the reasons why you are having to classify this. And also when it comes to estimate of cardiovascular risk in the next 10 years, then it helps you to categorize which patients you need to treat aggressively. So generally this table will be one of the good things you need to invest in. Now, the other important thing to know is so basic, but it's important. How do you take blood pressure? A lot of us think of how you take blood pressure. I think some people might have been lucky to have a resource center and they have gone there to know how to take blood pressure. I think I will just highlight the essentials. One is that your patient should be seated upright and should relax for 5 minutes before you take the blood pressure. And then you should do a series of blood pressure measurements, preferably 3. But if the last 2 differ by the last 2, then the last 2 are the ones you should record the average pressures. And if you measure the pulse and you find that the patient has an arrhythmia, it is best to leave the digital and use the manual system. And be very careful about your cuff. Your cuff should fit well. It should not be too tight and not too loose, because that will give you wrong readings. And the cuff should be positioned at the level of the heart. And use also the 1st and the 5th phase of the Korotkoff sign. And in the beginning, if you are assessing the patient the first time, you can measure both the left and the right. And the arm with the highest pressure is one you will use. Also record the heart rate and the pulse, as I said, because it might give you some differences. Ideally, you need to know that if the patient should not have taken coffee or tea just before you take 30 minutes or 1 hour before you take your pressures, because that will also increase your pressures. So having said that, then you need to know that sometimes a lot of your pressures that are done in the hospitals are done wrongly. And based on that, you need to know how to find your ways to do your pressures. And that means that maybe once in a while, if you're not happy with the pressure that is being done, then you will ask your patient then you do the pressure yourself. Now, commonly, sometimes you will do blood pressure measurements. And once you do your blood pressure measurements, once the pressure is 120/80, I think you tell a patient you don't have hypertension. But indeed, I think what you should do is you tell the patient, yes, you don't have hypertension, but ensure maybe in the next 5 years, you still take your pressure so that we see how your pressure is behaving. And then if your patient has normal pressures, that's 120 to 129 to 80 to 84, then you tell your patients to repeat your pressure in 5 years. The essence of this is that you know that as you age, your pressure will increase. And if you're not hypertensive, you can easily become hypertensive. And the patient has to know that it's not a disease that once you don't have, then you will never not have. So that's the essence of it. And then you need to also, if you do your blood pressure and you find it is high normal, as it is here, then you need to consider that one, that this patient may be having masked hypertension. So you will ask the patient to repeat the pressures at least annually. In my opinion, actually, it's not annually. I'll tell the patient to repeat in the next six months. And sometimes, personally, I will tell them that when they are at home, if they have a machine or if they don't have a machine, they could do a bit of the serial measurements sometimes and just record it and come back and look at the serial measurements, which is what is called home blood pressure monitoring. So in the earlier days, during, let's say, almost 10 years ago, or if you look at American earlier guidelines, this is what is called pre-hypertension. So that if you measured your pressure and found your pressure as 130 over 139 and 80 to 89, then you tell your patients the chance of you developing hypertension in the next 5 years is 15 to 20%. So you try to tell the patient to adopt lifestyle changes, lifestyle associated with treatment of hypertension, reduction of alcohol, stopping smoking, and doing exercise, and the others that you will do, because you know that this patient has a chance of developing hypertension. And then once you do your pressure and you find it's more than 140/90, then if, for example, your blood pressure has been done and then you're not trusting that, you could decide to repeat the pressures in your office, or ask the patient to come for repeat blood pressure measurements in the office. Or you could ask the patient to do home blood pressure monitoring. Or sometimes if you're very, very, very aggressive, then you'll do what is called ambulatory blood pressure monitoring. In this particular case, especially if your patient is a bit more stubborn and is not very, whatever, then you can do ambulatory. Ambulatory blood pressure monitoring just means that you have a machine, just called an ambulatory blood pressure machine, that you actually put a cuff, and then it has the blood pressure machine. But the blood pressure machine, you can attach it on the belt of the patient. And this blood pressure machine will be taking the blood pressure depending on how you have set it, predominantly usually every 30 minutes and every 30 minutes. And it will plot everything in the map, it will take the information in the machine. And then after 24 hours, you remove that machine and then put it in the computer, and it will tell you all the blood pressures that have been done, and it will give you an average of the blood pressure at night and at day, as we shall see in one of the slides, to just confirm for you. Now, medical students, what will be the history that will be important when you are looking at this particular patient? So one is family and personal history of hypertension, any previous history of stroke, or any other cardiovascular disease, and renal disease. And this is important when you're doing cardiovascular risk assessment, and also when you're trying to look at the targets for the blood pressure control. And then also when you're looking at family and personal history of familial dyslipidemia or hypercholesteremia, because it's also an important factor in influencing your cardiovascular risk. Smoking history would be important as part of your smoking, dietary history, and salt intake, alcohol consumption. And all these are important, especially when you are trying to target a non-pharmacological treatment. Aspects of physical exercise, erectile dysfunction, not so important per se, sleep or snoring, hypertension, previous hypertension in pregnancy or eclampsia. So if you've had previous hypertension in pregnancy or preeclampsia, it also tells, and then after that, you got better, it just tells you you also have a chance of developing hypertension in later. And that also helps you to confirm that patient most likely might have hypertension. And the other personal history that you should be able to get is just have an idea. Do you have headache? Do you have vertigo? Do you have impaired vision? Do you have symptoms suggestive of stroke? Do you have a history suggestive of dementia, especially in the elderly? And this history is more or less suggestive of, you're trying to find out if there's element of target organ damage. So does the patient have chest pain? Does he have shortness of breath? Does he have edema? And you're looking at aspects of coronary artery disease or heart failure. And then you're also looking at the kidney, polyuria, nocturia, hematuria. And you're looking at aspects of target organ damage or cause of hypertension in form of secondary hypertension. And then you're also looking at history suggestive of peripheral artery disease as part of the target organ damage, and family history of polycystic kidney disease. It might surprise you that maybe it's not as common, but as you start doing a lot of ultrasounds, as renal ultrasound in patients with heart being the hypertension, you start to realize that some patients just have polycystic kidney disease, and that is what is causing them to have hypertension. And finally, some of them will develop end-stage renal disease. Now, the other aspects of hypertension is what is called secondary hypertension. And when we talk about secondary hypertension, we say, if you're looking at a layman's language and they're trying to say what is called essential hypertension. In essential hypertension, you have looked for any cause of hypertension, but you've not found it. But in secondary hypertension, you have looked, your hypertension is secondary to something else that is causing hypertension. And commonly, if you have hypertension in the young, less than 40 years, or sudden development of hypertension or rapidly worsening hypertension in patients who are generally stable, then you start to think that is this possibility that this hypertension is secondary. So you need to have an idea about, is there a history of renal or previous chronic urinary tract disease? Is there a history of drug use? Steroids tend to be most serious in our setup. Nasal vasoconstriction, not so common in our setup, but those are some of the things that you need to remember. Now, you have history suggestive of headache, anxiety, palpitations, which is suggestive of pheochromocytoma. You need to ask about history suggestive of acute weakness or tetany. That is more of a hyperaldosteronism. And then you need to ask history suggestive of thyroid disease or hyperthyroid, history of current pregnancy, and history of sleep apnea. Those are some of the histories you will ask to try and find out whether the hypertension is secondary. Now, as I said, that this talk is designed in a very basic way. So we need to find out, why do we treat hypertension? Now, we treat hypertension because if we don't treat hypertension and you follow up those patients with hypertension for over like 15 or 20 years, almost 30 to 40% of them will have strokes, and almost 20 to 25% of them will have acute coronary syndrome. 50% of them will almost develop heart failure, and a significant proportion, hypertension and diabetes are the most commonest cause of chronic kidney disease. And sometimes if you don't treat it well, it progresses to worse hypertension. And also hypertension significantly contributes to mortality. And having said that, also your patients will develop peripheral artery disease and others will develop retinopathy. And those are the reasons why you're trying to treat hypertension. So in a nutshell, I try and tell my patients that you're trying to buy insurance against this target organ damage, which can generally be very, very expensive for you. So it's more or less, you have to tell the patient that you're not treating the patient on how the patient is feeling, but the future complications of the hypertension, so that they're able to conceptualize, because generally they are used to getting treatment just for a short time, like maybe bacterial infection, and then they stop the medication. So they can't understand why you're giving them medication for a longer period of time. Now, it has not been commonly, when I try and talk about hypertension, to talk about this. But this is what you will find. A 10-year cardiovascular risk score category tries to help you in form of trying to target which patients will require aggressive management in your patients. And sometimes if you're hypertensive, to just know how you're progressing. So the very high risk patients, these are patients who generally, if you followed them for 10 years, they're more likely to have a cardiovascular event. So these are some of the patients who have previously had acute coronary syndrome, patients who had, and they were treated, patients who have had a TIA, patients who have an aortic aneurysm, peripheral artery disease, or stroke, and patients who have had plaques that are almost 50% stenosis, either by ultrasound or the carotids. Diabetic patients with target organ damage are also part of the high cardiovascular risk. If you have chronic kidney disease and your GFR is less than 30, so all these patients have a 10% risk of developing a cardiovascular event when you follow them up. And then you have the high risk patients who will tend to have either one of these: elevated cholesterol, grade 3 hypertension, or familial hypercholesterolemia. The other people are patients, most patients with diabetes. They are also at high risk. Then if you do echo or ECG and you find left ventricular hypertrophy, these patients are also high risk. Echo or ECG showing you that they have LVH just tells you that this patient is developing target organ damage. Also, patients with moderate CKD have a calculated cardiovascular event in the next 10 years of between 5 to 10%. And then patients with moderate risk are the ones with a calculated 10-year cardiovascular risk of between 1 to 5%. And these are patients with grade 2 hypertension and also middle age in this particular. And then you have the low risk group. So sometimes patients with very high risk, you might need to treat their pressures to actually almost to normal blood pressure. That is a bit more lower than the high normal. Now, this becomes slightly a bit technical and more difficult for you, but generally we go back and say, so what's your definition of hypertension in the office? So your definition of hypertension in the office is anything above 140/90. Either one of them being higher or both being higher, then you have hypertension. However, if your patient comes and then is able and comes and doubts and says, no, I'm not hypertensive, and then you do an ambulatory blood pressure monitoring. Ambulatory blood pressure monitoring, as I explained, you have a machine that measures blood pressure continuously for 24 hours per day, and then puts it on a graph and finally gives you an average. So usually, without being very, very complicated, if you look at that ambulatory blood pressure and you find that the blood pressure is more than 130/80, or one of them, then the patient is hypertensive. And the essence of why it's a bit lower is pressure follows like a circadian rhythm. Tends to be a bit very high during the day, more so in the morning, and very low at night. So you also need to tell your patients to really know when they're taking their pressures. And therefore, that's why the ambulatory blood pressure is slightly a bit lower by 10 millimeters of mercury when you're using an ambulatory BP, an ambulatory. However, if your patient is taking blood pressure at home frequently and the machine is able to average it and is using the machine maybe alone, then your definition of hypertension is more than 135 over 85, either one of them or both of them. Then that's your definition of hypertension. So it becomes a bit more complicated, and therefore, if you're running a hypertension clinic which is more aggressive, that's where this will apply. And usually in undergraduate, we don't ask them. Just in case we want to make their life a bit more difficult, then we should be able to ask them about ambulatory blood pressure and home blood pressure. I think ambulatory will be a bit more better to ask, but usually we never focus about that. But I think it might be important to start asking in the exam so that we start to conceptualize. So for most of you, this is very straightforward. But as I said, the assumption is that you're talking to a first year and up to a sixth year. So we just need to have an idea of how do we able to work up our patients. Usually you do a full hemogram, you do a fasting blood sugar or a HbA1c. And the reason is a lot of hypertensives are more prone to diabetes and vice versa. Now, the other thing is you need to do lipid profile. And the reason why you are doing lipid profile is the fact that it is also one of the factors that might contribute to target organ damage. Then you need your potassium and your sodium to just give you an idea whether you're having hyperaldosteronism. Uric acid is also like one of the cardiovascular risk factors that you need to have an idea. The function of the estimated glomerular filtration rate is important. And the liver function tests are also important because of your medication. And then urinalysis, you'll do macroscopic, which you're using a dipstick, and you can also do microscopic when you're looking at microalbuminuria. Then your ECG will give you a rough idea about your heart and target organ. So I think this assessment, ECG, urine albumin creatinine ratio, and estimated GFR fundoscopy generally help you to look at target organ damage. So that's, as we can say, mainly about your assessment. This slide starts to look a bit more complicated, but it's trying to say when should you be able to initiate your blood pressure treatment. So that if you have high normal, as we said, you start to advise your patient to do lifestyle changes as if he's a hypertensive. Based on what we said, is that these patients almost 10 to 20% chance of developing hypertension in the next 5 years. So the more they start doing lifestyle changes, the less likelihood that they will delay the progression of hypertension. However, in the very high risk group, in the slide that I showed you, these patients who have pressures of this high normal will be considered to start treatment for hypertension, because that tends to reduce their chances of developing a cardiovascular risk. So this is why you are having actually that chart. In grade 1 hypertension, you might, if a patient comes and he doesn't have, he's not high risk, or he has no risks as pertains to that chart, then you might advise the patient to do lifestyle changes. However, if the patient has high risk or very high risk, then you might need immediate drug therapy to start on this particular kind of patient. But if the patient has low or moderate risk, then you might have to adopt lifestyle changes and then review the patient after 3 months and see whether the patient has been adherent to those. And then if he has not, then you start your treatment. Grade 2 and grade 3 hypertension, you do lifestyle and start immediately on treatment. And your aim for treatment is to get control in 3 months. Now, sometimes you are very aggressive. I think my experience tells me that if your patient is a bit young, you can be a bit more aggressive to achieve your treatment. But if your patient is a bit elderly, 60 and above, but you might need to gradually reduce their pressures. Some patients, when the pressures are reduced aggressively, especially the elderly, they start to have symptoms like when they stand up, they feel like they're dizzy. So you might need to focus on gradual reduction, especially the elderly, to reach targets. And therefore, you might require to see your patients a bit frequently. I think we will jump that. So when we talk about treatment based on lifestyle changes, so what do we mean? Salt restriction, reduction of alcohol to 14 units per week or less than, 8 units for women, taking diet that is high in vegetables, fresh fruits, and fish, and low consumption of red meat, and then reduction of body weight to achieve a good BMI. Regular aerobic exercise, 30 minutes of aerobic exercise, almost 5 to 10 days per week is recommended. And smoking, stopping smoking. Those are the things that we talk about when you talk about lifestyle changes. So if you want to be more scientific and say, look, what do those lifestyle modification and have on the impact of blood pressure? So weight reduction can give you a significant of as much as almost 20 to 10 millimeters of mercury per 5 to 10 millimeters of mercury for 10 kilograms loss. And these are the kind of patients that sometimes when they come to your clinic and they're really overweight and they're just having grade 1 hypertension, or sometimes even grade 2 hypertension, we could encourage them that actually the weight reduction will actually make them not take medication. Adoption of a DASH diet will give you almost 8 to 14 millimeters of mercury reduction in your pressures. And salt reduction will give you 2 to 8. Physical activity will give you 4 to 9. And moderate alcohol consumption will reduce by almost 2 to 4. So it really, this is basically from science, evidence proved. So just a summary, because we want to give you too much in a short time. And we also have people who have never done hypertension. So which drugs do you have? You have the diuretics, and here you have those different thiazide, loop, aldosterone blockers, and then you have adrenergic inhibitors. And here you have the common ones. We have the beta, then you have the alpha blockers, and some which have both alpha and beta. Then you have central agonist blockers. Then you have peripheral agents. Then you have direct vasodilators, the likes of hydralazine. And then you have calcium channel blockers, which are dihydropyridine and non-dihydropyridine. Then you have ACE inhibitors and angiotensin and ARB blockers. So when you start to treat a patient with hypertension, we expect that if, for example, you have a patient who has a grade 1 hypertension, that kind of patient, you might have to consider monotherapy. However, once you reach grade 2 hypertension, then you will need to use 2 types of medication, dual combination. And they can be in a single tablet or they can be separate. Commonly, we tend to use single tablet. And the best combinations that have been known to work very well are the angiotensin enzyme inhibitors or ARBs, and you combine them with calcium channel blockers, or you combine them with a diuretic. Those seems to be one of the best medications that tend to work in hypertension treatment. So combining this with this, or combining a calcium channel blocker with this or this. However, also some recent studies have shown that you can also combine a calcium channel blocker and a diuretic, especially in our setup, and they will give you reasonably very good blood pressure control. So that is as per our guidelines here, at least in Africa. This is a European society. Now, you're doing a dual combination for your patients and you're not reaching your target therapy. Then you can proceed and do a triple combination. So a combination of 3 drugs. So ACE inhibitor or ARB with a calcium channel blocker and a diuretic. So calcium channel blocker, diuretic and ARB, or calcium channel blocker, diuretic and ACE inhibitor. All those combinations generally will give you a very good control. Now, another concept that you need to be introduced to it is what is called resistant hypertension. That if you have used 3 types of antihypertensives and you're not getting well controlled, then you have what is called resistant hypertension. And if you have used these types of combination, 3 medicines and you're not getting whatever, then one of the best methods to try and get better control is you could do an addition of spironolactone. And you'll be surprised that a lot of our patients, we don't use spironolactone in hypertension because we tend to use it more in heart failure than hypertension, but it gives you a very significant blood pressure reduction, especially in resistant hypertension. The other thing that you could do is use a loop diuretic. In resistant hypertension, you could substitute this or do an add-on. Most likely substitute this thiazide-like diuretic with a loop diuretic, and that gives you a very good control. Or additionally use an alpha blocker or a beta blocker in your particular patients. Now, for Europeans, they tend not to use beta blockers as frequently because they feel like the beta blockers will not give them a good blood pressure control. However, what they indicate is that if your patient has heart failure, has previous coronary artery disease, has atrial fibrillation, or your patient is generally a bit younger with a slightly higher heart rate, this kind of patients tend to do far much better with a beta blocker as one of their drugs for treatment for hypertension. So there are 2 things that you need to take off from this slide. Is if your blood pressure is 20 systolic above your target and 10 above your diastolic, you need dual combination. If your dual combination doesn't work, then you'll go to triple combination. Once you've used triple combination and you're not getting good control, then you need to consider that patient to be having resistant hypertension. However, you need to be sure that the patient is compliant on treatment before you start saying that the patient has resistant hypertension. Beta blockers are good if you have an indication that requires a beta blocker. But additionally, in the young patients, when you say young is less than 50 years, who tend to have a slightly higher heart rate, like 80 and above, will significantly benefit from a beta blocker. Now, I think this just tries to say exactly what I've tried to talk about in patients who have resistant hypertension. And then sometimes if your patient has resistant hypertension, you might have to consider using ambulatory blood pressure. And then you need to consider essence to do pseudo-resistant hypertension, especially patients who are not adherent to their therapy. So you need to be sure that the patients are adhering to their therapy. And then you also need to consider patients with the resistant hypertension are more likely to have secondary hypertension. So look for the cause of secondary hypertension. And then this about low dose spironolactone, or if your spironolactone is giving you a side effects like gynecomastia, then you need to consider eplerenone, amiloride, which will still give you more or less the same effect that you have like spironolactone. So having said that, it's also important to look at what is secondary hypertension and what are the commonest causes of secondary hypertension. So you need to consider what is called obstructive sleep apnea. And this you can ask commonly from the partner or somebody who sleeps maybe with that particular patient to give you a slight idea obstructive sleep apnea contributes to almost 5 to 10%. In a more advanced setup, you can use what is called sleep studies to do a diagnosis of obstructive sleep apnea. Renal parenchyma disease is one of the things that you will need to consider, and that's why you do your urea and electrolytes. And then renal artery stenosis, what you call atherosclerotic renovascular disease or fibromuscular dysplasia, is also another common cause of secondary hypertension. And usually, we do Doppler ultrasound of the renal arteries. The problem with Doppler ultrasound of the renal arteries is that it is operator independent. So that if you did your Doppler ultrasound of the renal arteries and the patient, you're not able to pick the renal artery stenosis, and you're really convinced this patient has renal artery stenosis, you can jump, and I've done this, you can jump and do CT renal angiography, and that will give you evidence of renal artery stenosis, because that is not operator independent, and that is from personal experience. I've had a patient who did Doppler ultrasound, and it was normal, and I decided to jump and do CT renal angiography, and you're able to pick renal artery stenosis, then you can do an intervention. Now, the other causes are endocrine causes of secondary hypertension. Primary aldosteronism, pheochromocytoma, where we do 24-hour urine for catecholamines, Cushing's syndrome, where you need to investigate whether you're using dexamethasone suppression test, thyroid disorder, where you need to do a TSH to just look at whether there's an abnormality, hypothyroidism, which we tend to do a lot by looking at the calcium levels, and that will give you an indirect level about that. And then coarctation, which we say commonly, you commonly will be able to pick it up with an echo, especially when you do something called suprasternal view. However, that is when you're doing proximal coarctation of the aorta. But when you're looking at a slightly distal coarctation of the aorta, even the echo will miss it. And therefore, if you have a very good radiographer, when you're asking for CT renal angiography for the renal arteries, usually a very good radiographer will also do this and do angiography of the aorta, and he'll be able to pick the kind of distal coarctation of the aorta that tends to be present. And that's actually from one of the personal patient, one of the experiences. We had done an echo and it could not pick, and when we asked for a CT renal angiography, we were able to get a very good radiographer who was able to pick distal coarctation of the aorta, because it's very difficult to pick it from the suprasternal view. So, having said that, generally, it gives you a brief about hypertension, evaluation, and treatment. And now, because hypertension is a cardiovascular disease, and it causes other associated with a lot of cardiovascular disease, we want to move at hypertension in the COVID era and cardiovascular disease. So I think when I was being talked about this talk, there was a talk that why are hypertensives significantly more in the patients with COVID-19? And first and foremost, we must look at the science to say it's true that the hypertensive patients are slightly more involved. So this slide is a slide of many studies. Predominantly, I think they were done in China and other areas that were able to show that the patients with COVID and hypertension have increased mortality. This is the risk ratio of patients with, so there is 1.9, others as high as 3.2. But finally, if you're able to calculate and do an average worldwide, patients with hypertension and COVID have risk ratio of dying of 2.2%. This is the final summative risk ratio. So the risk ratio of dying is 2.2 if you're able to combine many studies. So it is true that patients with hypertension and COVID are more likely to die more than other patients without hypertension. So that one we have able to prove. So the other proof is that also patients with hypertension are associated with severe COVID disease. So also with the same different tests, the risk ratio of developing severe COVID disease with intubation and ventilation and ICU care will vary from 1.7 to 2.9 to almost 3.5. But finally, when you do a total, you'll find the risk ratio is 2.04. So it's true that when you have hypertension, you're more likely to have severe COVID disease. So that is already proven, as we are seeing from these studies. Now, also, they try to look at the patients with hypertension who developed acute respiratory distress syndrome and also were able to get ICU care. And we were able to find out that from different studies that the chance that you have hypertension, the risk ratio that you have hypertension, and you develop acute respiratory distress syndrome, and you land also in ICU is 2.1. So it is true that hypertensives are significantly affected by COVID disease if they have two conditions together. So is it only hypertension or the other comorbidities that are associated with a significant worse disease in COVID? So if you look at the COPD, chronic obstructive pulmonary disease, the hazard ratio of going to ICU, being ventilated and dying when you have COVID is 2.6. That is to say that you're more likely, you're in a layman's language, you're saying you are likely to be admitted in ICU, be ventilated, or die if you have COPD and you have COVID. 2.6 chances of dying, double. So diabetes also is associated with 1 times 5, 1.5 hazard ratio of ICU, ventilation, and death. And hypertension in this study was associated with 1.5. However, we have seen the other hazard ratios was 2, but in this study, it was 1.5. In this study, patients who had malignant tumors as a comorbidity were the ones who are most likely to have ICU, ventilation, and to die. They were the highest, followed by patients with COPD, then followed by diabetes, then followed by hypertension. However, in this whole study, they say that averagely, if you have one of these comorbidities, then you are more likely to have a hazard ratio of 1.7. You are likely to have ICU, to be ventilated, and to die by at times 1.7. However, if you had more than 2 comorbidities, your risk of having ICU, ventilation, and death, the hazard ratio was 2.5. So the more comorbidities you have, the more likely you're going to have a serious impact. No, so to just summarize, another study has included more other things as risk factors for progression and severity of COVID. One is if you are older, and I think this has come out clearly, but however, this is just a slide to tell us. We have talked about hypertension, we have talked about diabetes, however, we have not talked about smoking. Smoking also is a risk factor of having severe or disease of COVID. Cardiovascular disease, heart failure, stroke, coronary artery disease, you're also at risk of severe COVID. COPD, we have talked about it. CKD, we have not talked about it, but you're also at risk. And malignancy, we have talked about it as risk factors of severe COVID disease. So, how does COVID cause severe cardiovascular disease? What's the pathogenesis? So COVID infection is initiated when you have the S protein in the COVID virus that attaches to the host, which is a human angiotensin converting enzyme 2 receptor. So after attachment to the receptor, then it mediates the entry into the cells. Now, which are the organs of the body that express angiotensin receptor, angiotensin converting enzyme receptor 2 receptors? They are the pulmonary epithelia, cardiac myocytes, and vascular endothelia. And hence, that's why the disease tends to be very aggressive in the respiratory and the cardiovascular, and that will explain that. So just to give you a cartoon or a picture view, is that you have the S protein on this COVID virus, and the S protein comes to attach to the angiotensin converting enzyme receptor 2. And this receptor is the one which mediates the viral entry into the cells, and finally the replication into the cells. Now, once the AC2 receptor has mediated that, there's an element of downregulation of the AC2 receptor. And usually, when you have a downregulation of the AC2 receptor, then you have an upregulation of angiotensin type 1 receptor. Angiotensin type 1 receptor tends to mediate acute lung injury, adverse myocardial remodeling, vasoconstriction, and vascular permeability. Angiotensin 2, angiotensin converting enzyme receptor 2, usually mediates the conversion of the angiotensin to angiotensin 1 up to 8, angiotensin 1 to 8, which is important for the counterbalance of this that is happening. So therefore, as we shall talk in the next slide, this angiotensin 1 to 8, angiotensin 1, just generally tends to be less than usual, and that is responsible for so many of the other things that we will be able to find. Acute lung injury and the rest. This is just a cartoon more or less for the same. So it's more or less what we are talking about. That once the AC2 receptor is depleted, then you tend to have less of this angiotensin 1 to 2. And this is angiotensin 1 and 2 usually tend to give you anti-inflammatory activity, antithrombotic, vasodilation, and tissue protection. So therefore, you tend to have excessive expression of the angiotensin 2 type 1 receptors, which will therefore cause tissue injury, vasoconstriction, and prothrombotic and pro-inflammatory. And that explains the problems that we are having. It's more or less the same that we are talking about now. So this is an electron microscopy of the SARS virus with the S receptors that are the protrusion, and this is what gives them the name. The spikes out of that gives them the name. This is like an electron microscope of the COVID spike protein. And this is the S part that is attaching to the angiotensin converting enzyme 2 receptor. So this is the part that it attaches. Now, upon attachment of the AC2 receptor, the S protein is cleaved to generate S1 and S2, and the S2 subunit induces membrane fusion and viral endocytosis of the cells. So once in the cells, the viral RNA are released, and then they are processed to viral particles, which fuses with the cell membrane, and then they are also released outwards for further infection to the other areas. So this is more of what we are saying. AC2 receptor primarily converts angiotensin 1 and 2 to cardioprotective peptides, like angiotensin 1, 2, and angiotensin 1 to 9, and angiotensin 1 to 7. And therefore, loss of this angiotensin 1 to 7, angiotensin 1 to 9, from the surface potentiate cardiac damage. Additionally, the loss of the AC receptor 2 of the vascular endothelium increases endothelial dysfunction, inflammation, and thrombosis. So this is just pictorially to show you the AC receptor and then the way it is binding to the S unit of the SARS, the S unit of the SARS, the receptor. So this is just pictorially to show you. Now, so this is more or less the same repetition. The attachment of the COVID virus, the S virus to S2, diminishes the expression of the SC2 receptor and therefore compromises the cardioprotective action of the angiotensin 1-7, angiotensin 1-9. However, also reduction of the SC2 receptor induces massive cytokine release. And massive cytokine release is what they say it to be cytokine storm. But indeed, the mortality and morbidity of COVID is not really the virus, but it is the cytokine storm, the acute inflammatory reaction against the cytokine that is responsible for the morbidity and mortality. And that's why you've heard that sometimes when you give a low dose of dexamethasone, your patients tend to have less morbidity and mortality. Now, as we said, reduction of the SC2 receptors induces a cytokine release and also causes the dysregulation of the renin-angiotensin system, as we have mentioned above here. So, therefore, the cellular effects of what you have talked about, inflammation, thrombin formation, vasoconstriction, apoptosis, as we shall mention other, worsen the cardiovascular disease and also cause new onset of cardiovascular symptoms. So if you're looking at cardiovascular complications of COVID, as per basic subdivision, you can divide them into electrical and to the mechanical, as we're going to see in the next slide. I think we will jump this. So you can divide them into the electrical, which will cause you to have arrhythmias, and they can also be responsible for death. VT, ventricular tachycardia, ventricular fibrillation are the most commonest cause of death, all the arrhythmias. And then you're looking at mechanical, and this mechanical, we're talking about pericardial disease, we're talking about myocardial disease, we're talking about valvular, we're talking about vascular, that will arise because of COVID. So this just gives you a pictorial view. The SARS will affect the AC2 receptor, and once that affect the AC receptor, they start to, the cells, there'll be release of cytokines, there's a regulation of the renin-angiotensin system, there'll be sometimes apoptosis, as we shall say later. So one of the markers to look for, do you have cardiac injury, is a raised troponin. I know that you've done acute coronary syndrome where the coronary syndrome is, where the coronary artery is involved, and you commonly use troponin as your marker for acute coronary syndrome. But I want to expand you and expand your understanding and tell you that troponin is not only produced only when you have acute coronary syndrome, it is also produced when you have inflammation affecting the myocardium. It is also produced when you have the myocardium working so hard, and also produced when you have infection. So as a marker to find out, is your myocardium affected, you generally do troponin. Having said that, what this is just trying to tell you is that the mechanical aspects of the of COVID on the cardiovascular system is coronary artery disease, heart failure, and additionally, electrical is arrhythmia, but this is a shorter version. Now, the next slide will tell us that if, okay, this just tries to tell us that we'll pick one of the studies that any patient who had COVID and tended to have increased troponin, it showed that the patient had cardiovascular, specifically myocardial injury, was associated with decreased survival. And we're going to show you later. So how does COVID cause you to have arrhythmias? So a lot of patients with COVID will have issues with electrolyte imbalance, potassium and magnesium, and that will be responsible for eliciting arrhythmias. Hypoxia, because of acute respiratory distress syndrome, will have an impact on the conductive tissue and the myocardium itself, and therefore makes it easy for the patient to develop arrhythmias because of hypoxia on the myocardium and hypoxia on the sinoatrial node, atriometicular node, and the Purkinje fibers. Now, the use of medication in desperation, especially in the early phases, and some people will still believe chloroquine, hydroxychloroquine, azithromycin, and the antivirals are associated with prolonged QT interval, and that is a substrate for arrhythmias. And then also activated angiotensin receptor type 1 receptor is associated with activated protein kinase and associated with arrhythmias. Increased availability of calcium in the myocardium and in the tissues is also associated with provocation of arrhythmias. And then finally, the viral protein of SARS themselves were known to promote arrhythmias. The viral proteins themselves, I think here they are mentioned. So those are the pathogenetic mechanisms of arrhythmias in a COVID patient, and arrhythmias themselves will also cause death. That's one. So then we come to the mechanical dysfunction. And now we're looking at pericardial damage. These patients will have pericarditis and pericardial fluid. And this is thought to that the elevated angiotensin 2 might cause the inflammatory cascade, plus the other interleukins and the other cytokines might be important to promote pericardial inflammation and therefore pericardial inflammation and fibrosis. Because it's a new disease, we are not so sure that maybe if you followed up this patient who had some pericarditis, maybe 5 or 10 years, whether they'll develop constrictive pericarditis or not. That we are yet to find out. So I think this just gives you an idea that you have the SARS, it provokes the formation of the cytokine, and directly also the direct effect of the virus also causes myocardial dysfunction. And then this causes the other problems that you will have. So the first one we talked about mechanical was pericardial disease. And now we talk about myocardial disease itself. And the myocardial disease itself presents in different ways. You can have an acute coronary syndrome, as we saw in one of the pictures, in patients who have COVID. And then you can have the inflammation of the myocardium itself, myocarditis. And then you can have heart failure because the myocardium itself is affected. And then most of the time we don't talk about Takotsubo, but this is a disease that was discovered in Japan, that in fact, stress, a significant stress can somehow impact on the heart and therefore give you a low ejection fraction. And this is called stress cardiomyopathy. Long before the COVID, it is a new disease which has come like the last 10 or 15 years. It's called Takotsubo cardiomyopathy or stress cardiomyopathy. that the fact that you have an acute stressful condition because of the catecholamine storm, plus other things that we are to find out, can just give you a cardiomyopathy with a low ejection fraction. So the stress that you have COVID, and you don't know whether you're going to die or not, can also affect your heart. And then finally, shock. So what is the pathogenesis of the myocardial damage? One is the systemic inflammatory response that is occurring because of the cytokine release, which we are calling cytokine storm, and the impaired immune activity. All those cytokines and impaired immune activity that is will lead to damage to the myocardium. Now, the cytokines themselves will facilitate production of reactive oxygen species and nitrous oxide, which will also affect the myocardium. The SARS virus itself is directly myotoxic and can cause programmed cell death. And so that was some of the pathogenesis of myocardial damage. Now, because of the stress itself, you have an increase in catecholamine surge and microvascular dysfunction that might decrease the ejection fraction and therefore cause that stress cardiomyopathy. Now, also, you have increased oxygen supply and increased oxygen, so you have increased oxygen demand and decreased supply, and then if you have a mismatch and therefore causing hypoxia, which will cause an acute coronary syndrome-like and also impact negatively. Now, additionally, the stimulation of hypercoagulation, microthrombi, and excessive plaque rupture. And therefore, you have a hypercoagulable state. And that explains why all patients with COVID, you must give them anticoagulation. But they have a pro-coagulant effect that is provoked by this, and that will also cause cardiac ischemia, acute coronary syndrome, and that explains why all patients must always have anticoagulation in form of low molecular heparin or unfractionated heparin continuously during their admission in the ward. I think all this we have talked about then. So this just to, medicine is not about an emotion, but it's about proof. So you might observe something, but if you observe something, you must be able to prove. So one of the ways is they took patients who had elevated troponin and they assessed the patients who had elevated troponin. And you can see here in different studies in the China, even the US and Italy, and they found that your hazard ratio for death was 4.5, 4.6. Here it varied almost 80.1. This is hospitalized patients. So once your troponin is elevated, your chance of death significantly increases. So this is more or less the same. They were trying to compare the patients who had troponin versus the ones who did not have troponin. And they looked at the prevalence of the ones who died versus the ones who are the survivors. And you can see the ones who died had significant elevation of troponin. So it's telling us that once you have myocardial damage, your mortality significantly increases. And that's explained. So this is more or less the same. Prognosis of patients with and without myocardial injury. So this is the rate of survival, the percentage of survival. And these are the patients who had cardiac injury as per the troponin. And these are the patients who didn't have cardiac injury, who had normal troponin, abnormal troponin. And when they followed up this particular patient, you'll find that the survival in patients with cardiac injury was almost 50%, vis-a-vis the survival of patients without cardiac injury, which was almost around 98%. So that tells you that cardiac injury influences your mortality. Now, having said that, that if you look at what we have is a rheumatic heart disease, that even the angiotensin receptor 2 receptor is highly expressed in the cardiac valves, more so in the aortic valves, and that these patients tend to have some inflammation and fibrosis and valvular sclerosis. And it's a bit too premature to really say what this inflammation and the fibrosis will do in future. But maybe if you follow up this patient for 5 years and maybe 10 years, 20 years to come, then maybe they might develop something similar to what we are having in rheumatic heart disease. But the initial insult will start to cause the fibrosis and sclerosis that will later lead to a valvular disease in future. We don't know. We are yet to follow up these particular patients and see. So they also have valvular damage. Now also the angiotensin, as we said, we said expression of the angiotensin type 2 receptor tends to push towards vasoconstriction and systemic inflammation, but may worsen the hypertension through oxidative through oxidative stress and endothelial dysfunction. Now, the SARS virus provokes thromboembolism, and therefore hypercoagulation is one of the manifestations, and it is thought that the hypercoagulation is brought about by the presence of that cytokine storm. And I've said, as I repeat again, all these patients must have anticoagulation during their stay. So we are almost coming to our end. Just as a medical student, sometimes you're looking at what is your marker, but you suggest the patient is having hypoxia. So what is your marker that you will use to say the patient has hypoxia? So commonly you'll use oxygen saturation. Initially you'll use a pulse oximeter, and then later you'll use a blood gas of arterial blood saturation, and that will give you a marker that your patient is having acute respiratory syndrome, acute respiratory distress syndrome secondary to COVID. And we have talked again, how can you assess if your patient has myocardial injury? From whatever cause, is you do a troponin, and that gives you an idea of the myocardial injury. Most of these patients, so how do you know that the patient has some element of excessive coagulation? So you do a D-dimer, which are produced by degradation of the fibrinogen products. That will tell you there's some element of thrombosis. And most of these patients have elevated D-dimer. And then, how do you know that you have heart failure? So from your previous heart failure studies, you've done what is called pro-BNP, which is produced by the distension of the cardiac chambers. So if you did your pre-BNP and you find it elevated, you generally have heart failure, especially in this era where we're talking about heart failure with preserved ejection fraction. And then how do you know you have a problem with the function of the kidney? This one you know is creatinine. So what are your markers for a cytokine storm? Generally, we tend to use CRP. It gives you an idea of the patient having a cytokine storm. Now, we have not. You could use CRP or interleukin, but the interleukin is yet to be abundantly available, even for the advanced hospitals in Kenya. So, having said that, and you know that we've mentioned a lot of SC angiotensin converting enzyme in receptors. We are talking about angiotensin converting, angiotensin type 2 receptor. So that has been all along. So initially, there was a feeling that if your patients were using SC inhibitors or ARBs, then your patients will get worse. Or it will potentiate the entry of the COVID virus into the cells. However, subsequent studies have actually shown that that is not true. But in actual fact, there are small studies that are actually saying that ACE inhibitors and ARB may reduce the inflammatory response through possible inhibition of the interleukin-6. And we look at some small study. So this study looked at, these are small studies. Unfortunately, they said to give a very good conclusion of the study that you need to use it to put it in the guideline, you must have a randomized study. But most of these studies are not randomized because this is a new disease. And therefore, they just give you a preview, but using the preview, you need to do a randomized study to prove your point. So this is a study on patients' COVID mortality of patients who are not using ACE-ARB versus the patient who are using ACE-ARB. And this, you look, this is the percentage of death. And this is the time between the duration. So they found that they actually, paradoxically, unlike what they thought, the patients who are using ARB and ACE inhibitor had less death than the patients who are using, than patients who are not using. So the hazard ratio was almost less. The risk that you will die was even less than half if you're using ARB or ACE inhibitor in this particular study. And therefore, it begs the question, and somebody has to do a randomized study, whether we should be giving our patients ACE inhibitors or ARB as part of the treatment to reduce mortality. And this is one of the things that maybe we need to consider. I mean, if we were KU Hospital, which is having a lot of these patients, it'd be a nice study to do, and to do a match study of the patient with the same age, not hypertensives, to give them AC and ARB, and monitor the pro-BNP, troponin, interleukins, mortality, morbidity over a long period, and find out whether ACE inhibitors or ARB indeed can be used as a part of the treatment, even when your patients are not hypertensive. Now, based on the observational studies and a few studies, therefore, the several societies that deal with hypertension and heart failure, like the Heart Failure Society of America, American College of Cardiology, American Heart Association, American Society of Preventive Cardiology, recommended that if your patient has been taking an ARB or ACE inhibitors, they should continue taking them, don't stop them, which was slightly different from the original recommendation which they were trying to stop. However, they actually say that because these patients tend to have morbidity and mortality benefit, that actually withdrawing of those ACE and ARB inhibitors will increase the mortality and will increase the morbidity. And therefore, it is important that those patients who are using those medications continue using them, and you don't stop them. Now, this is not important, it's never talked about, but there's a small study which looked at the hydropyridine calcium channel blockers. These are the likes of nifedipine and the amlodipine. And this was a retrospective study. And they say that there's some element of higher chances of survival and less likely to require mechanical ventilation. You know, you are 50% in this particular patient. They did a retrospective studies and found that the patient who had hydropyridine calcium channel blockers were 50% likely to survive, and they are 14% likely to have mechanical intubation. But this is a retrospective study. Just gives you a preview, but it's not randomized, so it doesn't give you. So this is how it is. If you compared the patients who had whatever is almost going off. If you compare the patients who had calcium channel blockers they are more likely to survive than the patients who didn't have a calcium channel blockers. So there are also patients with calcium channel blockers. They were least likely to be intubated than the patient who didn't have calcium channel blockers. So I would like to end there. I don't know why this, whatever is saying that my battery is going off and I'm seeing it charging. Okay, fine. Questions?
Thank you very much for your presentation, especially the end. It was very interesting. I know that many people have been wondering about antihypertensives and if they should take them or stop them. So thank you for clarifying that. We have a few questions. The first one is, how can you differentiate COVID-19 from copulmonale clinically?
How can you differentiate COVID-19 from copulmonale clinically? No, that's a very difficult way of differentiating. But having said that, is usually copulmonale will tend to be plethoric. They will, some of them might even have some element of finger clubbing. Their saturations, though will be less in both. You tend to find them a bit puffed up. They might have barrel chest if they have COPD in nature. So it's a bit more difficult to really differentiate, but there's a maybe telltale signs that you can pick from the beginning. But usually the copulmonale patients who will have had COPD, those are the much more easier ones to differentiate. But commonly, of course, the echo will give you, and sometimes even the echo might be not as much, but might be a bit more similar by increase of pulmonary pressures, which are slightly a bit more higher.
Okay. The next question is, they say that hypertension is a silent killer. With regards to COVID-19, which of the complications of hypertension are most bothersome? Which complications of hypertension are most bothersome in dealing with COVID-19?
Which of the complications? Oh, okay. Okay, I think the ones which we will say that will be more bothersome will be the acute coronary syndrome, then followed by the heart failure per se. I think those are the ones which will be reasonably more bothersome. And of course, then you have the myocarditis perspective is also, but of course, heart failure is relatively more or less related to the myocarditis. So acute coronary syndrome and myocarditis will generally be most bothersome.
Okay. Then we have another question from Gitao Kamau. He's asking, when we achieve the therapeutic goals, what drugs can we use that have disease-modifying benefits?
When you achieve the therapeutic goal for?
Hypertension, which
Yes.
drug can you use that has disease-modifying benefits?
Okay. Now, I think of all those drugs, the ones which have the best disease-modifying, AC and ARB, they really tend to give you the best because one, they are renoprotective in a particular way. And sometimes even some ARBs have been found to somehow delay the onset of hypertension. And ARBs also have some element of ARB and AC inhibitors have some element of reduction of the left ventricular hypertrophy. But having said that, it is said that in Africans, the AC inhibitors alone as a single therapy for use for hypertension might not give you as adequate control as what you will expect. And therefore, in Africa, especially if you have grade 2 hypertension, you will find that most often you will need to combine that ACE inhibitor or ARB with a diuretic or calcium channel blocker to give you maximum hypertensive benefits. Unlike the white people, the ACE inhibitors, ARB, tend to be very well controlled with their hypertension. Our response to hypertensive control in blacks is not as good as the whites. But once you add calcium channel blocker and a diuretic, then the response becomes reasonably good enough. ARBs and ACE inhibitors tend to give you the best additional benefit.
Okay. There's another question. Is there anything special in the treatment of isolated systolic hypertension because the body depends more on diastolic pressure for perfusion?
Okay, really nothing is special. And isolated systolic hypertension is predominantly a disease of the elderly. Now, you are young. During our time, when we were younger, and I hope you also don't have very old teachers, there was significant focus predominantly only on diastolic hypertension. And that during our times, people were ignoring systolic hypertension. However, there was a SHIP study, something called SHIP or something like that, in the 2000 there, that showed that systolic hypertension is as horrible in form of causing cardiovascular mortality and morbidity as diastolic. And therefore, you still need to treat systolic hypertension to target. Having said that, there might be variations of treatment here and there that will give, but whichever medicine you use, you still be able to control your systolic hypertension. I hope I've answered that question.
Yes, I think you've answered it. A question from another participant is, once you've controlled hypertension, what rehabilitative therapy can you continue with?
Okay. You treat hypertension to target. Once you've treated hypertension to target, before even you start treating hypertension to target, you will need to combine both of these. So when you say rehabilitation, I assume that it is what we are saying non-pharmacological treatment. So you will, of course, advise your patient not to smoke, not to take alcohol, advise them about DASH diet, advise them about this is your target BMI, this is what you need to get about your target BMI. And then additionally, of course, there are other things that we tend to do. Look at the cholesterol and find how the cholesterol is and treat cholesterol to target. And then, of course, you tell your patients about the exercise that they need to take. So that the patients need to do all those things concurrently with their therapy. And therefore, the patients will benefit even from other things. For example, if you did exercise, you will still delay your development of diabetes if you're hypertensive. And you're hypertensive, you're more likely to develop diabetes. Just the same way it is diabetic, you're more likely to develop hypertension. And of course, exercise, even if you have a heart failure nowadays, or you have acute coronary disease, exercise is still advised even after an event. So those same things that you will be using the non-pharmacological therapy, your patient should continue with them. And that helps them to reduce their pill burden.
Yes. Still from the same user, in case the patient has renal dysfunction, what is the best drug to continue with from the groups of drugs you had mentioned?
Yes. Now, you see, the problem with the renal dysfunction, you know, if you're to go back and I've looked at the participants, and I'm having a feeling that your participants have predominantly been the 4th year, 5th year, 6th year. So I think it's easier to talk about it. That when you're talking about chronic kidney disease, then you see that you have different stages. You have stage 1 up to stage 5, or you have mild, moderate, severe, and what, depending on your GFR. So in the earlier stages of almost stage 1, stage 2, stage 3, the earlier mild to moderate, ACE inhibitors and ARBs are generally an excellent, and they're known to preserve the kidney function. So you need to consider adding them. But having said that, if you're using that for mild and moderate chronic kidney disease, and if you're using the ACE inhibitors and ARB being number 1 in your prevention of progression of chronic kidney disease, you need to constantly look at your potassium and your renal dysfunction. If you're using the ACE inhibitors and you're monitoring your GFR and you find that your GFR is coming down, especially in the chronic kidney function, then you need to look at and find out, is there any other cause? If there's none, then you might have to consider withdrawing. But generally, ARB and ACE inhibitors in mild to moderate chronic kidney disease tend to preserve more the kidney function. But if you don't have that, it is said the best medicine is to control the pressure. So that if you're not having ACE inhibitors and ARBs in your armamentarium to control hypertension, control the pressure, 1. 2, control the cholesterol. 3, if the patient is diabetes, control the diabetes. So the chronic kidney disease in a patient who has hypertension has to first control the pressure, and in the treatment that you are using, use ACE inhibitors, check your potassium, and ensure that your potassium is not going so high when you're using ACE inhibitors. Focus on other things like cholesterol and control them to target. If they're diabetes, control them to target. Prevent insults to the kidney. NSAIDs are significant insult to the kidney, so you need to watch up and try and substitute them with other analgesics that you are using.
Yes. Okay. Samuel is asking if you could explain the pathophysiology of secondary hypertension in obstructive sleep apnea.
Obstructive?
Sleep apnea.
Yes. That's a bit more difficult. I think I have not read of late. I've not seemed to really have focused on that obstructive sleep apnea, so I might not be up to date. That I will leave for some other day. But I know it is responsible for that, and ideally it will also give you some element of pulmonary hypertension and what. But I've not read out of late, and therefore I cannot concretize and give you that pathophysiology of the sleep apnea. I have some idea, but I think the way I'll explain it might not be an up-to-date way. So I think I'll let that question pass, and I think all of us can go and check it. I think the last time I did was a long time. I don't seem to have focused a lot on it. I don't seem to get a lot of patients, but I think some patients, especially the obese ones, tend to have a lot of that.
Yeah. Okay, we'll check on that as well. I think it's an interesting question. Another question is if patients with high normal blood pressure can be considered as a high-risk group for developing severe COVID-19 disease.
I think high normal are they considered as a risk factor? I will say it is difficult to say that because we don't have data. So we have to go back and do data mining and really look at the patients who had high normal pressures, and based on that, say that. The problem that we will have with that is the fact that sometimes your pressures in the hospitals are slightly different from maybe the pressures at home. And because they're having high normal, then you are not able to really categorize them unless they were coming. So it's a very technical whatever, and then also it becomes difficult to get funding for that kind of research. The only thing you can therefore get from that is data mining. You go and look at the average of patients' blood pressure and use a criteria and say this is the patients who are high normal.
and based on that, then compare with the ones who didn't have high normal, and then come up with something. I think it's very premature to say that. It's difficult. We don't have data. That's what I'm saying. I've not come across any data, but the problem is that we have so many other bigger problems. I think so that might be too small to focus on trying to pick that, but it's a good, interesting thing to see.
Yeah. So maybe that's a good idea for some research for the future.
Yes, the problem is that there are too many others to do that, focus on that one.
Oh, okay.
For example, if for example, as we are saying, small studies have shown calcium channel blockers are good, or ACE inhibitors are good. So now we need to pump in money and give patients with ACE inhibitors, and patients who are not even hypertensives, who are having COVID, and now see whether those patients will have better mortality and morbidity. You know, those are things that people are really struggling. Then there's a vaccine and the rest.
Yeah, so there's a lot of competition.
Yes, for that.
Collins is asking if digoxin has a role in management of hypertension, and if yes, at what point do we prescribe it?
So digoxin has no role at all in hypertension treatment. Completely no role.
All right.
Only in heart failure, and if you're talking about heart failure, systolic dysfunction, and in the West, they're not using it much. It has been replaced by what we call ivabradine. However, there are studies which, of course, if you're talking about heart failure, that's another day.
Okay. And the last question for the day is if ESR can also be used as a biomarker for cytokine storm.
What can be used?
ESR, erythrocyte sedimentation rate.
Okay. This is how we kind of grew up. Initially, as we were guys of ESR, and then later the CRP came. So the thing is, it looks like the Western world, where we are getting a lot of data, people have significantly moved away from ESR and they're focusing more on CRP. I will tell you the same. In my private practice, I never ask for ESR completely, unless I'm thinking about maybe a patient who has TB, and because I grew up in an area where we used to use ESR a lot in patients with TB, I never ask for an ESR. I just ask for CRP in private practice. So in the Western world, we have moved out, and I think the CRP gives you more information, is more accurate than the ESR. But having said that, it might be important that when these COVID patients come to our setup, that maybe we might start considering the use of ESR. Now, the other thing I want to tell you is that ESR also varies with age. The older you get, the older your ESR goes. I have to remember one of my lecture notes. There's a formula of calculating the normal ESR based on age. I think I'm trying to remember. So you need to be able to be very, very careful on interpreting ESR. As you get older, also your ESR goes high. There's a formula I have to really remember what it is, whether it is it has something to do with the age divided by something, the ESR or something like that. So ESR also varies with age, and therefore CRP is more accurate. We are yet to find out even more. There are some, I think Aga Khan, who seem to have pioneered COVID a bit more seriously. They are even struggling to do interleukin-6. So as time goes by, we'll find that we'll even get other better markers than CRP. So it's true that ESR maybe in our setup in a government hospital might be used. However, we need to know how to interpret it as per the age.
Okay. That's it for the questions. Although someone had commented about the pathophysiology of sleep apnea, saying that the sleep problems can lead to hypoxemia, which gives hypercapnia, And this triggers the sympathetic activities, leading to increased heart rate and blood pressure. I'm not sure I understand that part very well.
No, it is true. It is actually true. Is that in patients, they say the young patients, when we say young in hypertension is less than 50. So for people like us who are getting older, we are still considered young to boost your ego. So that's a joke. Now, the young patients in hypertension tend to have a hypersympathetic drive. And that hypersympathetic drive is the one which is the predominant aspect of the hypertension, especially in the young, obese. And when you look at the heart rate is a bit on the higher side, like maybe the upper 80s and 90s. Then when you look at that particular patient who has a hypertension with a high heart rate, it's trying to tell you that the pathophysiologic component of that hypertension is predominantly of a sympathetic drive. And based on that, the patients who will have obstructive sleep apnea will be predominantly the types that are obese. And that, therefore, anything that increases your sympathetic activity excessively will therefore tend to push you towards your hypertension, especially if it is persistent. So it fits well in the picture.
Okay. That's all the questions we have for you today. So thank you for giving us the talk. We really appreciate it. And now I'll hand you over to Abdirahman briefly.
Have a great day, everyone. And thank you again, Dr. Namasaka, for presenting this. We really appreciate your effort and your expertise. And also, I would like to thank our leaders of Executive Council and Standing Committee, especially the directors of the Standing Committee on Population Activity, Innocent Oduki, and the director of Standing Committee on Health and Environment, Ahaneku Kinaspere, for their leadership role. Have a good day, everyone, and thank you.
Okay, thank you. Good
All
night.
right.
Okay.
Thank you.
Okay. Goodbye, and thank you everyone for attending.
Okay.
I will end the meeting right now.